Hello, everybody, and welcome to Ask the CEO. Today, I'd like to introduce the founder and CEO of cliexa, an AI-powered clinical intelligence platform that helps clinicians identify at-risk patients and act earlier across multiple disease areas. It's my pleasure to welcome Mehmet Kazgan. Welcome, Mehmet.
Hi, Avrohom. Nice to see you again.
Yeah, same here. Nice to see you again. It's so wonderful to see you after all these years since the last time we worked together and to see how you've evolved.
Likewise. It has been great to see you again.
Awesome. So, Mehmet, the healthcare industry has gone through massive waves of technology adoption, from EMRs to interoperability to AI scribes. Where are we now, and what's the gap that still exists between what AI promises and what clinicians actually need?
Sure. So I think what's happening today is we're trying to find ways to elevate AI to get a lot of automation done. Like you're hearing a lot about agents probably here and there. We're trying to find ways to enable automation first so that in healthcare, you're not worried about trust, explainability. So instead of like trust and kind of explainable AI, that's what I want to say it here, is easier to get something automated in a very easier fashion. So that's kind of like what the healthcare market is doing. You've seen that path with AI scribes. It was easy to consume. It was easy to make sure that a conversation is happening and it's immediately generating the notes for the providers, for the clinicians. So you're seeing the market is enabling all these tools and making it happen for clinicians to really react something pretty quick in a very proper way. What is missing is the clinical reasoning. So getting something done in healthcare, it's not really getting you paid. That's the biggest problem. So if without having the reasoning that's baked into that work you're doing, either it's AI scribe or interoperability, combining data, making data work together without putting that reasoning, you're not going to make that solution or a feature actually give you the outcomes you're looking for. So that's what is missing today, the clinical reasoning, and that's what we're trying to fill that gap today.
So, segueing to that, cliexa's AI's opioid use disorder solution was recently qualified on Mayo Clinic Platform, and we'll talk about that in a moment. But just talking about the opioid risk assessment, traditional approaches to opioid risk assessment are often reactive and fragmented. Why is early proactive risk prediction so critical today?
It's a good question. I think the way that I'm going to answer that question is maybe talk about how like practice is going on related to opioids as kind of giving a picture of how today's market is. So it's basically a prescription, and we know that that prescription is causing addiction, overdosing, and other issues that we have seen over the 10, 15 years already. So what happens is we need to paint a picture for provider. If I'm going to prescribe opioids to get the pain away from the patient so I can address what's going on during that treatment process, what I'm missing sometimes, some early indicators of a problem that you will see in the future. And that's very hard for the provider to see. So you have a limited time of seeing the patient, limited time of looking at their information, aggregating it and synthesizing and making a decision. This is what I have to do with the patient. So it's very hard for the clinician to identify a risk for the patient at that point. It might also affect other comorbidities. For patients who are prescribed opioids, usually have mostly over 80 to 90%, we would say in US specifically, have another chronic condition. So how does that affect other condition? Are there any adverse effects with medications? It's hard for the clinician to say, oh, if I actually prescribe dose of X today, it might be a problem because of Y, because there might be a data point that you might have missed.
Yeah.
What we're doing today is looking at that closed loop, fragmented, pretty much data structured in a way and present it with benchmarking that information to the clinician to say, here's likelihood of the risk for this patient. And opioid use disorder model with Mayo Clinic Platform was the first pretty much like clinical decision support qualified in that marketplace for us, which will happen more in the future for our existing products as well. But we also provide the factors, the risk factors that causes that kind of predictive idea for the provider. In other words, we're not telling clinician this is exactly what's going to happen. We're saying likely this is what's going to happen, and these are the risk factors based on the benchmarks of patients you have seen in this industry. What you're seeing is more, we call it AI wrappers in the market, where they're enabling third-party LLMs or generative AIs like Anthropic and OpenAI. There's going to be a market shift you will see in the generative AI to offer their own solutions. We started seeing this already with OpenAI and Anthropic as well in the healthcare realm, but it's still important to understand that when you are building something, it needs to be built from scratch. I tend to give that example to people why preventing and seeing this feature is a problem from today is imagine you have a little baby playing in a room and you're going to constantly tell the baby, don't put your finger on that power outlet. That's kind of like restrictive modeling for what AI knows, like with the generative AI, versus what we are saying is our custom model doesn't even know the power strip exists on the wall. So it's kind of like limiting the factor by not introducing to the user, but benchmarking that information within that closed loop system where we trained already and we just quickly calibrate and realize that patient data and start making predictions. How will it help with the clinician and the patient? If you're actually doing early interventions for the patient and the dose management by knowing that risk in the future, better outcomes for the patient and actually less liability issues for the provider for any issues that can come up later.
So, Mehmet, what role do you see AI playing in shifting healthcare from reactive treatment to proactive prevention?
I think what it will do, again, I am thinking today, we will see the shift is going to change. What I'm saying today, AI will have another solution, another method faster than we think. The way that it's going to help is seeing what is going to likely happen is only going to work if you know the patterns that has happened in the past. So AI gives that ability to quickly recognize those patterns with some trained methodology, trained work, and quickly adapt it. It's another way to like maybe give this analogy to people. All of us probably, or most of us, have seen the Matrix movie on the first one, where the lady is getting like another helicopter pilot ability that she learns at that moment. Today in generative AI, even Anthropic or OpenAI started to add that skill feature where you can teach skills to the AI to start operate. But what we're saying is use the skill, but operate faster by calibrating into that reality. AI is going to get that better and faster as the infrastructure. That's going to be something we need to solve, where you have better infrastructure, better GPUs, better operating power. That's how you're going to have AI to start addressing that. Past 5 years, the infrastructure is growing as the GPUs instead of CPUs are utilized. Maybe quantum engineering is going to open doors, but the more power, the more ability we load to the AI in a controlled fashion with governance and policies and explainability and trustability. I think it's going to look at those problems faster and it can predict feature, but it's a continuous learning. It's not looking at a pattern and give you an output. It also watches the possible outputs coming up and kind of, we call it deep learning, and teach it to the system back. And everything is pretty much like doing it itself. But we're going to also see the human in the loop function. Where do we put it? Where do we put the approvals? How do we really monitor it? Those are the things we should be seeing pretty much even now as part of the coalitions that are gathering. How do we do AI governance? So we put guardrails around how it's going to operate as well.
And I think one key element that you mentioned was the data set, because everybody's out there is using ChatGPT and Claude and all these LLM products to analyze their doctor visits, their labs, even legal work, but ultimately it comes down to, you have a solid data set, you have a good product.
Correct. So I think the essence here is important. You're making that point. You're right. We started adopting AI, generative AI, very fast, which is, average users started to put their agents using ChatGPT or Claude today or other products to be able to do things for themselves. But we need to remember these solutions have been trained with public models. So their job is to generate. We hear this a lot. What is the method you do to avoid hallucination or bias for a product? We still need to do a lot of work, but data actually is the one we need to understand how we are activating data, which data set we're using to train a model. A model you train somewhere else doesn't necessarily mean it's going to give the same outputs that you're using in your use case because statistical information is going to change. Think about the data has been trained with female male ratio versus chronic condition ratio over 10% or 90%. That logic has been trained on with basic data sets and categorized data sets. When you take it to somewhere else, you need to build a calibration logic. So the system actually start calibrating the logic, avoiding bias and hallucination in that group that you're doing it. What we have done in our past is train in different multi-comorbidity levels, starting with chronic pain, and we go into rheumatology, arthritis, and cardiovascular with our partnership with American College of Cardiology, building rules engine to make that if-then-else statements. But those things also are dynamically changing in time with a controlled fashion. So when you train that, and then you just go and put this into another environment, it's the learning ability that makes intelligence powerful, meaning how quickly I can calibrate what I've learned versus, hey, this tool that I'm using is a generic AI model trained with billions of data points. It's giving me a good picture, but we already are seeing the solutions are kind of narrowing prompts and getting better. It's the personalization real time. So that solution didn't know and knew adverse effects just happened, and the timing within that adverse effects with the medication cannot apply how this model has trained. Sure, if you retrain that model in that closed loop environment, maybe it will learn, but until then, we need to close that gap with the users to have an idea versus this is really what possibly can happen to you with your gender, with your demographics, and this is the treatment that has been done in this facility with their data set. So we're talking about a closed loop learning data versus kind of like publicly trained millions, billions, trillions of data points.
Yeah. So, Mehmet, cliexa's opioid use disorder solution was recently qualified on Mayo Clinic Platform. What does that milestone represent for cliexa?
It's huge. I will say three big steps that this is cliexaAI pretty much applied to opioid use disorder. We have gone through, I would say, 3 years now since our first touch point with Mayo Clinic Platform Accelerate program. We're one of the first four companies selected to that program. I think there are over 100 now. So we're proud of being selected back in the day. So we have been also engaging with Mayo Clinic Platform's early days that we also got access to data and we started learning it. The learning was both ways from us, but also Mayo Clinic Platform as well. To date, after 3 years, the solution has been retrained with a lot of data points and then that data points and then interactions with Mayo Clinic Platform about how do we do accuracy, bias, hallucination, avoidance. Those things actually made our platform stronger. And then Mayo Clinic Platform has been asking questions and verifying data points, monitoring so that they're not going to put any solution to white label to be available to their network. It gives us this really, I would say, shiny badge that we're not an average solution. We have been actually put through a very, very detailed process of monitoring. I would say surveys, questionnaires, a lot of like matrices we were against with. So are we doing the things, are the outputs right? So that made us a valid solution in this environment. Number two, it's a big milestone. We're a fully white label solution in their platform. That badge having there and opening up to their network, that will give us a big growth opportunity to put our foot in the door with our opioid use disorder predictive solution. And the third one, we're really, I would say, unique in the market. We're the first and only platform, Mayo Clinic Platform's actually portfolio that does this clinical decision support for mostly on opioid use disorder, which you can expand, but it also touches other conditions. So that uniqueness also giving us a big market presence as well, not only in US, but overall in the world.
Now that is a really great accomplishment.
Mhm.
I've been
Thank
watching
you.
your progress over the years, so it's really
Thank you.
exciting to see that.
Thank you.
So, Mehmet, can you take us through how the solution works in simple terms that a clinical audience would appreciate?
For sure. So the solution literally works. We call it headless in technology. In other words, you don't have to introduce cliexa's interface to users. You can. We have those microservices, but this solution is fully containerized and packaged and deployed on the customer side, meaning this intelligent brain deploys and then kind of wires itself to data, starts already calibrating itself. Of course, we do maintenance with the human in the loop factor there, but this is running behind electronic medical records. So we can have the solution pretty much display the prediction for opioid use disorder along with the risk factors and other data points if it's requested or demanded. It's working in the electronic medical records in a little frame, in a tab, or you can just populate a new browser screen from there itself. So it's actually completely working within their workflows and their electronic medical record systems. We also keep saying this a lot. cliexa doesn't replace workflows, systems being electronic medical records, or people. We just optimize them, meaning we're giving the brain and intelligence running behind the scenes. You still apply your workflows, you still use your systems, you still use the same people. And this is behind the scenes. It's just staying over there and then giving you the picture within your own tools. And on a clinical like level, if you're going to see your doctor today, when doctor opens up the existing chart or the view for the patient within their existing tools, we're going to snap the prediction, high, medium, low risk, and the risk factors so they can make informed decisions today. That's how it works.
And for those that might not be so familiar with the term, could you explain what human in the loop means?
Absolutely. So when you say AI, AI can do everything for you or some things for you. When you say healthcare, you want to make sure that you're monitoring the outputs, the bias, and hallucination. So let's say you're going to teach a skill or have the solution use a guideline as a skill, maintaining like a prediction or gathering documentation. Take AI Scribe as an example, which most people are familiar. It's using a template when it transcribes it, it applies certain rules and it says this is what it looks like as a document, and you save it. That patient's note becomes a document from audio transcription into a clinical medical record. Through that process, you still need to make sure that the provider clinician are still agreeing to the output because it can still hallucinate, it can still make things in a different way. Before that system is generating a record, because it's trained to generate, so it can make things up. You still need to have a human in the loop to monitor and approve what is being recorded or transcribed or output so that you can say this looks like a golden record, which can create a new delta so the AI can learn, oh, I see that delta, now I know what to do next time. But even put that learning back into the system, you need to have a human in the loop approving that logic, saying that, yes, that's a good method to do. So human in the loop is kind of putting a governance on an AI solution that monitors and approves the outputs the way they want it.
And that should set a lot of people at ease when, people are afraid, can we really trust AI? There are all sorts of jokes and memes that are out there. There was one person that shared a meme about asking ChatGPT if a certain kind of mushroom is poisonous. And ChatGPT said, "Well, no, it's not. You can eat it." And then the next
Right.
scene, you see the guy's gravestone, and
There you
and
go.
ChatGPT said, "Oh, you're right. I was mistaken. Would you like some web searches on poisonous mushrooms?"
Treat yourself. Correct. Correct. That's a good example. So the model is trained to give you an output, which is not the output you expect, or there's certain risk with that output applies to it. In healthcare, you have even more, but that's a good example around. It's important for the system to be monitored and approved with those. So imagine in that workflow, before it gets like, is certain mushroom is poisonous, it says no. Before that, you put a human person who says, well, is this a good method? That person will say, well, make sure that you're monitoring the poisonous mushroom can actually affect people. Also check this ABCD so that you know that the output is useful or not risky for the patient or the subscriber or the user or end user. That's why we call it like the approval process and the AI governance. So who checks and validates it? How does that process enables that system using that learning back into it so the next user can consume it?
Yeah. Mehmet, what makes cliexaAI's approach different from traditional risk scoring tools?
I would say there are two major, I would say, differences and differentiators. Number one, we have been training this model for over 12 million data points for over the course of 9 years. As you remember, in 2019, when we were having our interview, I was speaking the same term, same language to say AI can learn, enable providers to, or the clinicians to make informed decisions, but we need to aggregate, enabled, and let AI learn from that pattern recognition in a closed system. Nothing changed from there. But what changed in 9 years, we started from that and up to today, cliexa actually became getting exposed to more data points, going through American College of Cardiology partnership and investment, Mayo Clinic investment, and Mayo Clinic Platform qualification process. The system got better and better by getting a lot of scars through that process, is understanding what needs to be done, what doesn't have to be done, or isn't have to be done in a way. So that's number one. Number two, it's the dual LLM. It's kind of like a large language model. It has the predictive piece and it has the generative piece. Predictive piece actually has 2 points, which it has the pattern recognition, but also the system can understand better with multi-comorbidity relationship. That's why the evolution of cliexa past 9 years through the condition, we always focused as a marker, as a data point, as a metric for categorizing the prediction based on comorbidities. If you have depression, how does that affect your other condition, or vice versa, as an example? The predictive piece, also using the generative custom model, which is unique, it has the ability to apply guardrails, guidelines, which we apply insurance guidelines, clinical guidelines. So the system is knowing what are my actually area of movement, first with the payers, and then the clinical protocols, and applying and personalizing at the moment of time where the patient is talking to the provider or the clinician. That means the dual LLM is operating with all that logic, which is unique. You will see solutions doing risk prediction based on, the image data identifying cancer, or EKG data identifying the cardiovascular risk. We are combining a cardiovascular risk with the oncology risk together and say these are the early indicators and multi-comorbidities that can increase the speed of the patient's progression, which we have done one project with a pharma company, Astellas. We were predicting chronic kidney disease, and the stages of chronic kidney disease, the speed of it, by understanding how a hypertension with type 2 diabetes exposed to a chemotherapy, how likely or quickly they can get the chronic kidney disease progression in a patient. that gives us a power and differentiator than other tools out there that we know of, makes us different for that predictive model.
Now, as you mentioned, you spent nearly a decade building up to this point. Can you walk us through the evolution of cliexaAI from the early days of smart intake and data collection to where the platform is today?
For sure. As you know, the market wasn't ready for AI
Yeah.
back in the day. So we need to find a product market fit to enable a convenience factor both for the patient and the provider. But if you think about a business, somebody needs to pay for your service. So we kind of identified maybe we can enable this for the clinicians first by onboarding the patients with the smart logic, aggregating, synthesizing data at point of time, but applying the pair logic so that both patient is transparent about what is going to come out of the pocket and what this clinic can do based on guidelines, because certain criteria is met for this visit or procedure to be applied or the visit to get paid. We collected that and then we applied and painted a picture between 2016 to 18 by saying, here's how this patient picture looks like, and this is how you can see real-time patient data in front of you. That was 2016 to 18. And we focused on, again, multi-comorbidity conditions, rheumatology, chronic pain, mental health conditions. I actually started my own clinic business to collect our data between that time. While we also build a partnership, we partner with American College of Cardiology to see how cardiovascular conditions, which is the number one killer in the world, how can we apply that comorbidity risk into our existing risk prediction model? So between 2018 to 21 to 22, cliexa evolved by focusing, adding the cardiovascular condition. But in our clinic, we started utilizing our own data to predict opioid use prediction in our chronic care facility. And then in 2022, that's where we went to Mayo Clinic Platform Accelerate. We got accepted to that program to say, we trained our model. Here's a use case on opioid use disorder. We don't want to boil the ocean, but it has the ability to do that. That's where we engage and started training, but also understanding the AI governance, fairness, accuracy, what process that you should be part of to validate your platform. And here we are today. We are addressing triage with AI. We're addressing the mortality risk in nurses' notes in ICU units. We had chronic kidney disease prediction model we enabled. Opioid use disorder platform for Mayo Clinic Platforms was another one. And we also signed up last year another customer in eating disorders, which makes this complex conditions manageable and enabled by cliexa's AI brain to show you data at point of care. How can you deal with complex conditions where you have multiple providers addressing the same patient from different angles? So that's kind of where we are today, and we're trying to expand it with new partnerships. Hopefully, I can't name it yet, but we are partnering with a very big entity to enable this also for government space, and we're excited to announce it pretty soon.
Great. So, from a provider or health system perspective, what tangible outcomes can they expect when implementing cliexaAI?
I would say, like, if you think about the earlier comment that I made, around I'm trying to build this as a framework as we build this. It makes total sense. As we said, we do not replace systems, workflows, or people. We optimize them. So if you enable cliexa in different ways, we kind of talk about for the patient engagement, for onboarding, scheduling, and what have you, or it is the provider or clinical engagement where you want to see what's going on with the patient, what is the best optimal care I can do with the patient within the tool I'm using, or we call it biller engagement, which is after the fact you do the service and you start to do the things that you can get paid for the service. That's how the model works in the healthcare system in the US specifically. If we think about cliexa, it's running as a brain in the background, enabling a patient to give the right and real-time information that makes sense for the provider during the onboarding, understanding what clinical treatments that he or she can get, and then answering those questions and understanding what's going on, again, with the brain running behind the scenes, it's going to increase patient engagement immediately, which is convenience factor, being transparent, and then also it's going to be efficient and convenient for patients to see what is the most optimal way that I can schedule this to get the best treatment that I'm looking for. From the clinician side, I save time because that picture we paint in seconds, and what can happen with the data we benchmark already with the treatments in that facility, it gives empowerment for the provider, for the clinician to make most informed decisions. We're not making a decision. We're 513G cleared platform. We're painting the picture, providing the clinician the best optimal that worked in the past. So that will give the provider empowerment on the most informed decisions. Again, it will result in best outcomes for the patient. It's going to get clinical outcomes like early intervention, early treatment, less medication adverse effects, and you can build on it. Which on the billing side, it will translate into an efficiency. So if you have a system that you know what you can do, instead of you're trying to do your best for the patient, but it's outside of the payer guidelines, which is going to cost you a denial and rejection. It will create a pill management cost and what have you. It will increase the efficiency for the biller in the short term, but in the long term, you're going to decline. You're going to see a big decline, which we see from early customers already within 3 months, up to 40% decline in denials immediately within the 3 months. Within the 6 months, 54% denials. And if you are an entity saying, this is our denial rates, and if you give that 35 to 50% average within 6 months, that's a quick dollar return translated for a health system to see what the outcome will be on the financial or revenue cycle side.
Now, you touched upon this a little bit before. One of the biggest concerns with any new clinical tool, as you know, is workflow disruption. How does cliexaAI integrate into existing EMRs without adding friction for clinicians?
Yeah, so I think the easiest way to tell the story is like we're running behind the scenes. So everybody, you, me, our families, our friends, everybody we engage with, we don't like change. It's a survival instinct. If we get out of our norms, it's not good. Our brain just responds quickly. It's the same for clinicians doing this work. So they're already struggling with inefficiencies of healthcare services model, billing and scheduling, and the complexities coming with medication and all that. So if you introduce a new platform, a new solution, they're going to immediately say this is not going to work for me, or it's going to be scary. So there's a risk of adoption. What we did from day one was how can we enable this information that we want to deliver so that the end user, clinician, or the patient can work within their own tools that they're already operating. So if you're a clinician, you're looking at an EMR, we implemented right now over, I think, 13 different EMRs bidirectionally so that we can display what we want to show, paint that picture within the tools they're using today. So we deploy it with fully integrated EMR systems. Some of them were resellers as well. The other part of it, of integration is if the solution EMRs, electronic medical records, have front-end portals where they are already engaging with the patient, cliexa logic also runs behind the scenes and enable those abilities on that solutions already in place by EMRs, either portals or apps or mobile applications. If they don't have any of it, we'll enable our solutions. We call it microservices to fill in that gap for them. That way, the system runs within their system. So you don't change anything. The same users, people are getting optimized. Workflows, the same. We don't change anything. You still follow the same thing. We're just doing it smarter. And then obviously the systems, EMRs, we're operating in the existing solutions already.
Great. And that makes it smooth and transparent for everybody.
It does.
Mehmet, can you share any early results, pilot learnings, or customer feedback that illustrate the real world impact?
Yeah, that's actually great to share right now with the ones that we have received for opioids for the clinic that we have been running, about 120 employees. 35% decline within the 6 months of the solution deployed for opioid prescriptions. So that actually declined 35% of opioid, enabling other ancillary services that clinic was offering with 272% increase in revenues. So you're avoiding what might possibly not work for a patient, but here's another solution they're offering with a proper way of putting a system in place to say, this is likely going to work, and they just kind of follow the protocols by cliexa enabling. So revenue increase, clinical side, you get 35% decline, but in the denials, but also from onboarding a patient and visit side, we also seen 16 minutes savings for a follow-up, like 45-minute to an hour visit that we have seen in our recorded sessions in real time. With the government entity, we actually took the triage conversation that happens on the call from average of 19 minutes to 7 minutes by guiding the clinician to triage the patient real time on the screen as well. These are very like clear, published, and I've been presenting this also in different areas. We have our third paper just approved by International Journal of Eating Disorders, where cliexaAI has been applied to Cartini Clinic's data, one of our customers. It was a great kind of output. But that actually gave us a great published scientific paper. It's going to be soon announced publicly, where we can actually do early interventions for eating disorder treatments weeks before, like the outcomes would possibly come through. So that's going to come out pretty soon on a published paper as well on a scientific paper. I'm so excited because this is, I think, one of the earliest, if not the first one, in clinical decision support in eating disorders applied by AI.
That is really exciting. And one of the things that I was thinking about when you were speaking, you had mentioned how the clinicians are guided by AI, which decreased the amount of time that they needed to, you mentioned like I think it was 7 minutes.
Mhm.
A big challenge you have in major healthcare organizations is patients getting the time that they need because healthcare workers are very rushed. It's just so inefficient nowadays.
Correct.
And you're seeing how you could do more with less, and people still get the care that they need, which is incredible.
That's totally correct. And I think the big evidence of that, like you're seeing again, the market shift, and then I will say the waves of healthcare. There's a big, I think, over $4 billion invested in AI scribe tools alone last year in 2025. I don't know how many of them are out there right now, but I always thought AI scribe is a feature, right? It just transcribe a conversation into a note using some, I will say, static logic. If you're adding a logic, a brain that learns the best optimal way of if you're going to generate a document instead of a post conversation, if you can lead, because if you follow a script as a provider, as a clinician, you got to ask certain questions, you got to collect certain information, you got to get certain consents. But those things that I just said is different from one patient to another, one visit to another, one insurance coverage to another, one protocol to another. If you can enable a complex logic that can operate real time, we call it cliexa, clinical excellence algorithms, and it learns as it goes. That's where the real innovation is. Instead of spitting out enabled AI wrappers go to the market, but really build intelligence. So we have been doing the hard work. So we're enabling those features to use a smarter intelligence layer. That's what our goal has been so far.
Talking about smarter intelligence, responsible AI is a major theme in healthcare right now. How does
Mhm.
cliexa ensure its models remain ethical, unbiased, and clinically safe, especially when patient lives are on the line?
For sure. So there's a methodology we have been learning and improving as part of Mayo Clinic Platform, conversations and co-development partners like American College of Cardiology. So we transparently show which data we have used, how did we use it, how do we test it. So there's a methodology, and those reports are pretty much what we're sharing with our customers. But doesn't mean what we did is going to work the same. That methodology still stays, and we have monitoring that introduces human in the loop that will show those kind of milestones and stages and outputs you can constantly monitor. So we have manual monitoring models where we give governance to our customers so they can see that as it goes. We also have automated controls and then monitoring that gives alerts. These are not AI solutions. This is a solution that gives outputs. It's a rules engine. It's kind of like running a query on a stored procedure saying, this is the expected value. This is what the system has been giving. So you can see the delta. That gives you an opportunity to see before, during, after it's implemented, how this is progressing, and it gives alerts that we implement. But we also enable like other solutions to monitor, implement in the cloud systems so they can use their own monitoring system to flag it. So that transparency gives them confidence about how it has been trained, how it's already executing in their environment with their data. If there are flags, we can, that's why we call it AI as a service. We can calibrate, tune the service that's necessary.
Now, for healthcare leaders watching this right now, why should they be paying attention to cliexaAI right now?
I think there are many, many reasons I will say that I have. But number one, the shift of AI is also introducing the governance and trustability layer for them to understand. So I feel very confident with what we have been doing past 9 years and our partnerships. We did a lot of hard work. We don't sell a marketing buzz or hype. We're literally sharing a solution that can calibrate that has been trained for 9 years now. It was called boiling the ocean for investors and advisors. But here we are. Our first qualification validation came from Mayo Clinic Platform for a reason. We have more. We have papers that we're getting approved, we're publishing. So they should pay attention instead of the convenience factor versus are they really getting the job done? For example, if you're implementing AI scribe as an example, everybody knows what they are. They're investing a lot of it. Yes, it transcribes, it creates, it's convenient for the doctor. Does it really get the entity, get the best patient outcomes with it? Plus, those notes generated are getting the clinicians, hospital systems getting paid. Because if you're not getting paid, that convenience doesn't mean a lot. That's number one. Number two, it's important to understand the system as a clinical logic that applies at every stage of the process during patient journey. So if you say I have a solution, just gets the note created, implement, great. Then you need to buy another tool to say, well, I need to enable this tool to create the note better. I need to have another tool to add it to the workflow. I need to have another tool. Imagine a logic, a brain that can operate a medical necessity justification for billing system, revenue cycle management, the optimal clinical decision support at point of care for the provider to see the best optimal care that has been recognized already within their system and what possibly can do by looking at different data buckets. And for the patient to understand what can happen to me instead of searching in ChatGPT. That's why cliexa is different, and that's why they need to pay attention and look at use cases we have done. So yes, we boil the ocean, but we have strong use cases. We apply this intelligence, either it's at claims intelligence, clinical decision support, or patient onboarding and patient clinical assistant at point of care, personalized real time.
If you had to summarize cliexaAI in one sentence, what would you say makes it unique?
It's the clinical intelligence that can understand clinical comorbidities at point of care and calibrate itself to that subspecialty immediately and starts giving the best optimal care outcomes for the patient and the provider.
Mehmet, how do people connect with you, and also where do they go to learn more about cliexa?
Yeah, our website, cliexa.com, cliexa.com, and they can email at info@cliexa.com for any information. And our website has lots of information to look through, but we're happy to have conversations, do discovery, and find ways how cliexaAI can help their entity to fill in white spaces. So again, we do not replace systems, workflows, or people. We just optimize them.
And I'll make sure to post all that into the show notes.
Thank you so much, Avrohom.
Mehmet, do you have any parting words of wisdom that you'd like to share with the audience?
I will say, please make sure you pay attention how the solution you're onboarding, either it's AI or not AI, what are the real outcomes that it can provide in your system, other than how you have seen other systems benefiting, because each organization is different. They have different people, systems, and workflows. Can that system quickly calibrate and get the outcome? This applies for all of us on our daily, I would say, consumption methodology. You go order online something, you just want to look at the reviews first, but you got to look at the reviews and read who that person is, why they bought it, and why they give positive or negative reviews. One review doesn't mean anything. You got to look at 10 of them. So I think we have a way of coming up with early judgment with technologies. Oh, this company is not Microsoft, not Google, not AWS or Amazon. Is this company really solving a problem? I would say give a chance to those entities like cliexa and understand what outcomes it can provide specifically to their organization, rather than let's simplify what we can see and look at the simple ROI. Doesn't mean that ROI will apply the same in your organization. That's, I would say, as a decision maker in those entities, to look into those, ask how the AI models are trained, which data sets, and start from there.
Mehmet, thank you for sharing your time and your wisdom. I really enjoyed having you on the show.
Thank you, Avrohom. It was a pleasure.